When you attend RSNA 2023, our industry influencers and radiology trailblazers are set to help you embrace what's next in medical imaging. Imagine what new medical imaging practices and technology can teach about collaboration and innovation. We have everything you need, all in one place as we help you explore how to lead through change. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Early bird pricing is available through October 4th. Register now for RSNA 2023 at rsna.org/register. Welcome to the RadioGraphics podcast. My name is Luke Linscott, and I'm here with my co-host, John Wood. Hi, John. How are you this afternoon?
I'm doing great, Luke. Thank you so much for inviting me to join you on the podcast today.
Great to have you, John. Today, we are excited to be discussing the pediatric imaging article from the July RadioGraphics issue. It is entitled A Radiologist Lexicon for Reporting Child Abuse. This comes from the Pediatric Radiology Group at Vanderbilt Children's Hospital with lead author Asha Sarma. So we call this an article, but it's actually more of a very brief online PDF that you can download, which introduces a more comprehensive but very concise PowerPoint presentation. And this PowerPoint presentation addresses how radiologists should report imaging findings suspected to be related to non-accidental trauma or child abuse. The PowerPoint focuses on three major areas: abusive head trauma, skeletal trauma, and thoracoabdominal injury, with its major focus on consistent use of specific terminology in describing these injuries. The slides are image rich, they're not overly wordy, and each of them has some nice reporting tips and key points that are highlighted. So John, what were your major takeaways from the paper?
You know, Luke, as I went through it, I thought this was a wonderful educational PowerPoint. It had great breadth and discussed a wide range of imaging findings for abuse. I thought the authors did an outstanding job illustrating some important imaging pearls that are crucial for not only general radiologists to know, but also fellowship-trained pediatric radiologists as well.
Yeah, my overall takeaway from the PowerPoint was this would be a great introductory resource for residents and fellows looking to understand this topic better, but also really quite a helpful reference for even seasoned attending radiologists. So the authors begin with a review of neuroimaging findings of abusive head trauma, and then they also include a brief discussion of spine injuries in child abuse. They start by reviewing various types of extraaxial hemorrhage with an emphasis on subdural hematomas and bridging vein injury/thrombosis. I really liked the slide that shows an example of a clearly acute subdural collection that's homogeneously hyperdense, and then on the other side of the spectrum, a clearly chronic subdural collection with multiple compartments and enhancing membranes. And then they emphasize that any other type of mixed CT attenuation or mixed MR signal subdural collection simply cannot confidently be assigned a time frame of injury. So it's a great reminder that we should be descriptive first and foremost in our reports and avoid dating these collections unless we're absolutely certain.
Yeah, I wasn't overly familiar with that, Luke. I thought that was a great point. So I guess the authors are pointing out that really we should be focusing on the presence of membranes to help date collections.
Well, yeah, in terms of the chronic subdurals,
Yeah.
enhancing membranes and compartmentalization are really the primary findings we use to identify a chronic subdural. So after discussing subdural collections, the authors switch gears and they discuss what findings we might encounter in the brain parenchyma itself from abusive head trauma. They emphasize the high association of cytotoxic edema in the brain with abusive head trauma. They warn against mistaking these findings for an arterial infarct and briefly discuss the highly varied potential mechanisms for this cytotoxic edema that we see in the setting of abusive head trauma. They briefly discuss parenchymal lacerations, the imaging appearance of parenchymal lacerations, and their association with abusive head trauma. That's followed by a really nice discussion about skull fractures and fracture
Yeah.
terminology. They distinguish between different types of skull fractures, including simple skull fractures that have 2 endpoints, complex fractures that have 3 or more endpoints, and comminuted fractures where you have bone that's completely encircled by a fracture or encircled by multiple fractures. And finally, they define a depressed fracture as one that has greater than 3 millimeters of offset.
Sorry, Luke, I was just previously referring to the parenchymal laceration teaching point, and that is, I think it's a great point. I wasn't too familiar with that originally, and when you look at the images they show of parenchymal lacerations, it looks very similar to encephalomalacia. And so I think that can be very confusing if you're not aware of the entity, especially to general pediatric radiologists. And I think even adult neuroradiologists alike can be confused by that if they're not familiar with that pathology and how it differs in new babies as opposed to teenagers and adults. I also really like on the skull fracture, their definitions, because I feel like during training I've had a lot of terms thrown at me and even in practice, and sometimes we just use these terms interchangeably, but we don't actually go back to the original definition and use them properly. So their point of a complex skull fracture having 3 different ends, I thought was fantastic, and how that can be different from comminuted, because I've seen that interchange quite a bit. And I also really appreciate the 3 millimeter cutoff for a depressed fracture, because sometimes it can be 1 or 2 millimeters and it may not quite meet that threshold, and we shouldn't be calling something depressed if it doesn't meet our guidelines.
Yeah, I really like the very systematic approach that they take to fractures and very clear, concise definitions. I think that will help us as radiologists and certainly will help our clinical colleagues. As they discuss these fractures, they talk about the relative frequency of each of these fractures in the setting of accidental versus non-accidental trauma. And there's a really nice discussion about skull fracture mimics, things like accessory bones, accessory sutures, vascular grooves. I thought the discussion of vascular grooves was a great point, especially in the era of 3D reconstructions. It can be very easy to be fooled by a vascular groove on a 3D reconstruction, thinking that it's a fracture. So that was a nice addition. And finally, the authors emphasize an important point that skull fractures show very inconsistent healing findings and really should not be dated or timed. The neuroimaging portion of the PowerPoint is rounded out by a brief discussion about scalp hematomas, retinal injuries, and spine injuries. I enjoyed the reporting tip for scalp hematomas. We should just say they are either present or absent. We don't have to provide any further commentary. In terms of retinal injuries, we are certainly much less sensitive to detection of retinal injuries than fundoscopic examination, but when we see them, we should make note of them as they are such a critical finding. And then finally, they end with a discussion of spine injuries, and that includes both subdural hematomas in the spine and ligamentous injuries. So overall, I think the authors have just done a great job of reviewing the neuroimaging findings of potential abuse with a nice emphasis on useful reporting tips and pointing out potential pitfalls. So John, let's turn now to you for a review of the skeletal and thoracoabdominal sections of the PowerPoint. What impressed you? What did you find useful?
Yeah, I thought this was a fantastic review of the skeletal survey, and also and highlighted important fractures and really what to look for. Now, these skeletal surveys typically have over 20 images, and they are easily overwhelming to read, especially if you're a general radiologist and don't look at them routinely. So knowing what to pay attention to and look for really makes a big difference and makes it much more manageable, whether you're fellowship trained in peds or you're not. The authors emphasize that every fracture should be mentioned in a standardized manner, and I thought this was a really crucial point. I've actually seen a lot of skeletal survey reports where the impression will just say, multiple healing fractures as above, or even in the findings, they'll just say multiple rib fractures. But I thought they did a great job stating that every fracture needs to be talked about specifically. I like to think that every fracture has a story and deserves attention. It occurred somehow, and that needs to be explained. So describing each fracture, its location, the morphology, whether or not it's displaced, and whether or not there's subperiosteal new bone formation is really helpful for somebody further on, a child abuse specialist, to look at your report and to determine what the age was and the mechanism of injury. I really appreciate the authors mentioning also the importance of correlating follow-up skeletal surveys with the initial one. When somebody reads an initial skeletal survey and talks about fractures, the follow-up skeletal survey should mention similar fractures. You don't want to get the rib numbering wrong, or you don't want to get right and left confused. And so if you disagree with the prior one, they mentioned a great point of getting together and coming to an agreement and consensus with your reports. And they're different and discoordinate, can look sloppy to a jury or child abuse specialist, and can be very confusing when working up the case. The authors did a great job mentioning bone mineralization. We all know that there's multiple mimics of child abuse, especially rickets and osteogenesis imperfecta. And it's important to always look and evaluate bone mineralization when evaluating these skeletal surveys. That helps us, pick up an unknown diagnosis and also potentially not overcall child abuse. I also like to throw out to talk about other signs of dysplasia or syndrome, such as, if there's excessive Wormian bones or Frater cup metaphyses. Those are also important to put in the report, especially if they're abnormal.
I was really impressed in this section by just how systematic their approach was to every fracture in terms of how we describe it, how we categorize it. That was really nice. I also appreciated how at the end of the PowerPoint presentation, the slide deck, the authors included standardized report templates for the skeletal survey. They also had some for head CT and brain MRI, but that's helpful, right? If a radiologist or a group of radiologists is looking for example standardized report templates, they have provided those.
Yeah, I thought that was outstanding that they included those. The more people we get to use standardized templates, the better, and the easier it is for everybody who comes along in the future to look at our reports. I also appreciate how the PowerPoint did a great job talking about morphologic descriptors for these fractures and describing whether or not something is a buccal fracture or a classic metaphyseal lesion. In the future will really help child abuse specialists correlate what we see on imaging with a mechanism of injury. We don't need to explicitly say in our reports how these things happened, but by giving correct morphologic descriptors, we will be providing information that somebody else can use to derive potential mechanism of injury and fill in a clinical history, which is important for these patients. I thought the discussion on the classic metaphyseal lesion was actually really on point. I wanted to highlight two things, Luke, that they talked about, and that was one, be wary of diagnosing a classic metaphyseal lesion above the age of 2. It's really a fracture you see in young children, young babies, because of their skeletal immaturity. And also that these classic metaphyseal lesions may not heal with subperiosteal new bone formation. So if you do a follow-up skeletal survey in typically 14 days, they may not have subperiosteal new bone formation. And that doesn't mean that the classic metaphyseal lesions aren't real. They could look the same or they can heal in a different manner, but they are still there. I also wanted to point out that this PowerPoint was really up to date. They referred to Andy Tsai's article about costochondral junction injury, which is frequently missed on skeletal surveys. So when the chest is squeezed, it can cause injury to the costochondral junction. This is highly associated with abuse. And they mentioned that in the different findings of costochondral junction injury, such as it can look like a bucket handle appearance, but it only occurs for about 2 weeks. And after that, the fracture will, it may not be apparent on skeletal survey.
Yeah, I agree. I appreciated that discussion of costochondral junction injuries. That was certainly an update of my knowledge base.
Yeah, I had heard about it before, Luke, but it really hasn't been emphasized previously. And I think we're recognizing it more and more and understanding the importance of those fractures in child abuse. Speaking of fractures, they also did a great job just specifying dating on these skeletal surveys. And it may not be important necessarily, put your dates in the reports, but you should comment on stuff somebody else in the future can date. So whether or not there's soft tissue swelling, subperiosteal newborn formation, or whether or not you see callus formation. They specifically broke out the days you can start seeing those. But if you put those signs of healing in the report, you will just lead somebody down in the future to derive timing of these fractures, which is really important. Then I also wanted to point out that they did a great job looking at normal variant versus classic metaphyseal lesions. Can't really do it justice describing it on this podcast, but they had some great references in there, some great reference pictures of what normal variants look like. And as they say, a picture is worth 1,000 words. So I think this is a great PowerPoint, like you said earlier, to have as a reference to look at. So a resident or an attending radiologist can pull it up and look at the normal variants to make sure they're not overcalling classic metaphyseal lesions. They also did a great job talking about subperiosteal new bone formation and how that may not be just from healing fractures. It can be physiologic, we talk about quite a bit, especially if it's less than 2 millimeters thick and along the diaphysis of long bones. Also important to remember, other things can cause subperiosteal new bone formation, such as prostaglandin therapy and torsion infection. And finally, I just wanted to highlight their discussion about thoracic and abdominal injuries. I thought they did a really great job with that. And basically, they just said we need to look at these and categorize them by the AAST classification system, which honestly, most radiologists are probably very familiar with because we read a lot of trauma examinations. So if we just stick to that standard classification system, and in particular, pay attention to those injuries that are more suspicious for abuse, such as pancreatic and duodenal injuries, then that's going to be very important in the report to highlight those for the child abuse specialist. So I thought this was a very straightforward approach, and I think that's very easy for us as radiologists to manage to do.
Thanks, John, for that review of the skeletal and thoracoabdominal sections of the PowerPoint. Just a great article. Once again, I'm very impressed with the author's systematic approach to evaluation and reporting of suspected child abuse injuries. For all those listening, I hope you get the chance to review this great presentation. I've got this in my reference files and plan to use it for both resident, fellow education, and as a personal reference. Thanks again for joining us on the RadioGraphics podcast.